as our speakers will be willing to answer them. And so now to begin the session, it's indeed an honor for me to introduce Dr. Hema Divakar to you. Dr. Hema Divakar is the CEO and chairman at the Asian Research and Training Institute for Skill Transfer. She has received the FICCI Award for Excellence in Capacity Building and is the division director at the FIGO Well Women Healthcare at FIGO. She has been the president of FOXI in 2013. She is an advocate for delivering quality healthcare as the convener of Manyata. She is an opinion leader and an influencer for social and legal issues relating to women's health. Over to you, Dr. Hema.
Thank you, Dr. Rita. And once again, on behalf of all my beloved friends who also are doubling up as distinguished panelists today, we welcome our very special guest, Dr. Chiara Benedicto. And therefore, I'm going to stop slide share for a moment so that the spotlight falls on our very beloved Chiara, whom I have known for many, many years now. And the contributions made by her in association with us at FIGO in particular, but globally in general, are just, mind-boggling. And the way her meticulousness, dedication, and commitment to always doing her best. She has few seconds to breathe here and there, but within that span, she manages to do a lot of things. So I will now move back to the slides for a formal introduction of our very special guest and keynote speaker. And following that, we may just take a question or two from the audience and then move on to the panel discussion, which will be moderated by none other than Padma Shri Manjula Anagani, and other distinguished panelists will soon also be introduced to you. So the second slide I want to focus first, author of more than 800 scientific publications. And I have had a very close and an intense taste of how Chiara works on her publications. It just really puts us all to shame because it is such brilliant pieces of work which is available to the rest of us to imbibe and gain expertise and knowledge from it. And going back to her formal introduction, she is, as we all now know, Professor Chiara Benedicto, FIGO Regional Trustee. She handles the region which is in Europe, and she's an ex officio member of the FIGO Committee on Women at Menopause, ex officio member of the FIGO Committee of Women at Reproductive Age, because in the trustee position, they do join our meetings to give their wise advice and, of course, great inputs for many, many productions of FIGO, as we call it. So, past president of the European Board and College of Gynecology and Obstetrics, that is the EBCOG, which Dr. Suchitra was mentioning about at the Congress where she met our dear guest. And she's Professor Emeritus of OBGYN at the University of Torino from Italy. She has contributed significantly to the standards of care of women's health in Europe and at the EU Parliament during her presidency of EBCOG. And we all recognize as leaders how important it is to connect with the national governments and national organizations to move the needle further for women's healthcare. She also began the EBCOG Simulation Consortium of hospitals and institutions aimed at broad implementation of simulation-based training in the field of OBGYN. We have to imbibe this more and more as we go along, working with Chiara in future for the South-South collaboration and for the Global South as well. She's presently the member of Care for Everybody. That's what she does, the Supervisory European Board. Now, on a global scale, she has been the FIGO Council member and the chair of the FIGO Women Human Rights Committee and the FIGO Committee on Refugees and FIGO Well Women Healthcare Committee as well. So I have already told you about the publication and the foundation that she has established, which is set up as a non-profit organization to impart safety and well-being in places of care and cure, named something in her language, but it translates into medicine tailored to the women foundation. That's what her foundation reads as, and we've already exposed Kiera on her commitment to the human rights and the refugees, and she has in-depth understanding. So whenever this topic comes up, we lean on Kiera for advice. So we are now proud to present to you our beloved friend, colleague, distinguished keynote speaker for the evening, Professor Kiera Benedicto. Kiera, before we actually recorded her speech only because if there are technical glitches, we didn't want to fail. And so Kiera is right here. So would you want to say a few words, Kiera, before we play your video?
First of all, it is a real pleasure to be with you and to join this important event. And as we can see, there is a group of very strong and dedicated women who are working together for the health of other women. So it's a pleasure to see you all, and hello to all the audience.
Thank you, Kiera. She told me that it is a holiday season for them, but she knows that once I get told a friend in need is a pest indeed. That is what is my definition with Kiera, because anything and everything that I ask her, she's always obliged. So thank you again, Kiera. And then on to the presentation, which is beautifully made. It's a short one, but then we'll take a question or two after that before we begin the panel. Yeah, please.
We need to switch on the audio before sharing.
Volume, please. We've not only put a lot of risk-benefit issues for MHT, but we are now, thanks to Kiera, we are working with the cardiology group, which has been quite an intense work, getting the experts together from two different faculties, the OBGYNs from FIGO and the World Cardiologist Group. And it is, watch this space, it is in the making. Yeah. Just can you go back a little bit and start from the beginning, please? And I don't think the volume is again heard. Yeah. Do you want me to try sharing? Can you move out of the slide share, please? Team Farmit, can you just move out of the slide share? Yeah.
Webinar. During my presentation, I will speak about...
Just let me know if this is working.
The screen is not up, doctor.
Okay.
The audio came
Yeah,
in.
audio you can hear, no? Yeah.
Yeah.
Then I'll just one second. Are we good now?
Hello to all.
Good, doctor.
It is a pleasure for me to take part in this webinar. During my presentation, I will speak about what's new in MHT, revisiting hormone therapy with confidence. First of all, when we think of menopause, we should take into account that due to the progressive increase in life expectancy worldwide, there is a strong possibility that a woman will spend 1/3 of her life menopausal. That's why post-reproductive health has become a global priority. And we, as FIGO Committee on Well Women Health and Care, have included the menopausal transition and postmenopause as one of the main focuses of our attention, aimed at prevention across the lifespan in the so-called FIGO wheel of prevention, well-woman care advice. On this particular issue, FIGO has taken a position stating that healthcare practitioners can and must protect the health of midlife women by increasing awareness of menopausal symptoms, promoting healthy lifestyles, and providing healthcare options, especially menopausal hormone therapy, which is the most effective treatment. We know that nowadays women are bombarded by contradictory messages related to MHT, such as, on the one hand, menopausal hormone therapy is a great opportunity, and on the other hand, MHT may be dangerous. Therefore, it is our role as gynecologists during routine consultations to clear up their doubts. And our challenge is to create a benefit-risk profile based on the most recent scientific data available, and to tailor with confidence menopausal hormone therapy to each woman seeking relief from menopausal symptoms. Current contraindications to MHT include a personal history of breast cancer, severe active liver disease, coronary heart disease, stroke, and venous thromboembolic event. However, these contraindications do not apply to transvaginal-based estrogen therapies, as the serum concentration of estrogen in this route is extremely low. Moreover, as we will see later on, women with a personal history of cardiovascular diseases may still be prescribed MHT, known to have a neutral effect on CVD risks. To obtain maximum efficacy in reduced potential risks, systemic MHT should be started as soon as possible after the onset of menopausal symptoms, at most within 10 years after the final menstrual period. There are no reasons to set arbitrary limits on the duration of MHT, and therefore MHT can be continued as long as a regular reassessment of the benefit and risk ratio is favorable. Now let's move on the potential benefits. First of all, MHT is known to be the best treatment option to alleviate vasomotor symptoms. It also reduces vaginal dryness, sleep disturbances, depressive disorders, and joint pain in most women, all of which lead to a significant improvement in a woman's quality of life. Many studies have also demonstrated that MHT reduces the overall mortality by 22 to 54%. And MHT has also been reported to be associated with a slower biological aging, that is, with a younger phenotypic age, calculated using chronological age and selected biomarkers such as telomere length and DNA methylation as compared to never MHT use. Furthermore, menopausal hormone therapy can be cardioprotective. However, this protective effect depends upon the timing of the treatment. In fact, when MHT is started within the first 10 years after menopause, it significantly reduces the risk of coronary heart disease, which is the leading cause of death in women worldwide. Conversely, when MHT is started more than 10 years after menopause, there is no protective effect. This strong and consistent evidence that hormone therapy may be cardioprotective if started around the time of menopause is referred to as the window of opportunity or timing hypothesis. MHT has also been approved for bone loss and osteoporosis prevention in postmenopausal women, as it reduces the risk of hip fractures by 33% and vertebral fractures by 32 to 38% compared to placebo, both with unopposed estrogens and combined therapy. Also, tibolone increases MMT and reduces fracture risk, even at low doses. Moreover, MHT may help prevent the menopausal changes in body fat distribution with a decreased visceral fat mass. It also improves insulin resistance and lowers the incidence of diabetes in postmenopausal women by 21 to 35%, according to various studies. It also has a favorable effect on glucose metabolism in women with pre-existing type 2 diabetes. Moreover, it increases high-density lipoprotein and decreases the LDL and LDL-HDL ratio. What's more, MHT yields a significant improvement in sexual function, mainly through improvement of dyspareunia. Tibolone is the most effective therapy in terms of restoration of sexual function, including desire and satisfaction. And some data show that transdermal estradiol may perform better than oral conjugated equine estrogen on psychological domains of sexual function, possibly owing to the lack of SHBG induction in the liver, and thus higher circulating androgen levels. As to cancer, it has been demonstrated that menopausal hormone therapy leads to a reduction in the incidence and mortality from colorectal cancer. And if it is given in the form of continuous combined preparations, it also lowers the risk of endometrial cancer, especially in obese women who usually have a high incidence of endometrial cancer than non-obese women. Menopausal hormone therapy, both in the form of estrogen-only preparation in women who have been hysterectomized, and in the form of estrogen-progestogen combined preparation, can also lower the risk of Alzheimer's disease when started within 10 years after menopause. However, in women without a uterus, when estrogen-only therapy is given after 10 years from the final menstrual period, the effect on Alzheimer's disease is neutral, whereas a combined estrogen-progestogen therapy in women with an intact uterus started after 10 years from the final menstrual period increases the risk by 32%. Therefore, the concept of window of opportunity applies also to neuroprotection. Last but not least, MHT may lead to a better performance on a broad spectrum of cognitive skills when started within 5 years from the final menstrual period. And this is particularly true for women undergoing surgical menopause. And it seems to limit the effects of stress on working memory, perhaps by adding in the maintenance of proper hypothalamus pituitary adrenal axis reactivity. Now let's move on to the potential risks. As to breast cancer risk, which has become a sort of nightmare for many women, a systematic review meta-analysis of 14 studies on MHT based on estradiol show that if MHT is given in the form of estradiol alone in hysterectomized women, or in the form of estradiol associated with progesterone or dihydrogesterone, the effect is neutral on breast cancer incidence. However, the combination of estradiol and other progestogens, such as levonorgestrel, natal medroxyprogesterone acetate, does increase the risk of incidence of breast cancer. Moreover, the long-term follow-up of the two WHI placebo-controlled randomized studies using conjugated equine estrogens demonstrated that when MHT was given in the form of CE alone in hysterectomized women, it significantly decreased both the incidence of breast cancer and the risk of death from breast cancer. In contrast, when women with an intact uterus were treated with combined formulations of CE and medroxyprogesterone acetate, they had a significantly higher incidence of breast cancer, although their risk of death from the disease didn't reach statistical significance. Tibolone has a neutral effect only if it's used for short periods of time, that is less than 5 years. Thereafter, it increases the risk. The combination of conjugated estrogen and baxidrositane has been shown to have a neutral effect on mammographic breast density and on breast cancer incidence in women followed up at 5 and 7 years. Recent papers, one using data from South Korea, 2 from Norway, and 1 from Finland, have basically confirmed that the use of systemic, oral, or transdermal estrogen combined with specific progestogens, tibolone, and vaginal preparation do not increase the risk of breast cancer, whereas the combination of estradiol and NATA does increase this risk. And in this respect, it is noteworthy that the increased risk seems to be related to specific subtypes of breast cancer and not others. In particular, it doesn't increase the risk of triple-negative breast cancer. Moreover, another important observation is that MHT use is not associated with worse survival from overall breast cancer, and in triple-negative breast cancer, it seems to be associated with an even longer survival. Another possible MHT risk is that of increasing the incidence of venous thromboembolism, both when MHT is started within the first 10 years after menopause and when it is started more than 10 years after menopause. However, this particular risk is influenced by the route of estrogen administration. Indeed, estrogen transdermal preparations do not increase the risk of venous thromboembolism compared with non-users. Conversely, oral preparations do increase the risk significantly. Moreover, the risk of venous thromboembolism also depends on the type of progestogen associated to transdermal estrogens. As a matter of fact, the combination of transdermal estradiol and progesterone has a neutral effect on the thromboembolic risk, whereas the combination of transdermal estradiol with norpregnane is associated with a significant increased risk, and the combination of transdermal estradiol and other progestogens, such as pregnane, nortestosterone derivatives, and other unspecified progestogens, does tend to increase the risk, although not significantly. Based upon these data, and on the results of some observational studies on women who experience a myocardial infarction, the British Menopause Society has recently stated that women taking MHT who sustain a myocardial infarction do not necessarily have to discontinue it. And women who have sustained a myocardial infarction and who then require MHT can be given it in the form of transdermal estrogens and non-androgenic progestogens. Moreover, they specify that the co-administration of a statin may bring further synergistic benefits. As to the risk of stroke, generally speaking, lifetime cumulative estrogen exposure decreases the risk of both ischemic and hemorrhagic stroke. Transdermal estrogens and oral estradiol decrease the risk of stroke, whereas oral conjugated equine estrogen increase the risk of ischemic stroke at intermediate and high doses. Moreover, the time of oral CE initiation from the final menstrual period may play a role, as the longer the time lapse from the final menstrual period, the higher the risk. Speaking of ovarian cancer, estrogen only and estrogen progestogen preparations increase the risk of serous and endometrioid ovarian cancers, whereas they have a neutral effect on mucinous and clear cell cancers. Tibolo increase the risk of serous ovarian cancer, and the risk of all epithelial of ovarian cancer if it is used for more than 10 years. In summary, when counseling women during the menopausal transition and post-menopause, we as professionals have to take the patient's symptoms, needs, and desires into consideration, as well as assess the individual risk profile, lifestyle, along with the presence of any contraindications to MHT. In the absence of contraindications, MHT should be started as soon as possible after the onset of symptoms, definitely within the first 10 years after menopause. Moreover, MHT type and duration should be tailored based on patient history, menopausal age, physical characteristics, and current health status, so that the benefits always outweigh the risks. Moreover, menopausal women should be advised to have regular reassessment of their health conditions, especially if they are on MHT. And now I would like to conclude my presentation by inviting you to read this FIGO position paper published in the IJGO, which gives you an insight into how best address the benefits and risks of MHT during counseling in menopausal women. Thank you for your attention.
Thank you so much, Chiara. And there are hundreds of audience delighted to have such eloquent talk and broad insights into what you have spoken. There are two key questions, because I'll let you go after these two questions, and moderator will take over for the panel. In India, we have a huge concern about the follow-up of the patient, even postpartum. Even whether it's the contraceptive advice or simple things like that, they will not come back. So given that scenario, how to increase the confidence in the providers to prescribe MHT, and what happens if these women are not available to us for a regular follow-up, because they may just not show up for many months or years. So what do you do in such a situation? Do you think it is still not risky to start? And is it perhaps the reason that we don't have the confidence? Chiara. Chiara, to unmute.
I think women should become aware of the pivotal importance of follow-up. I think probably we need to make social media campaigns and increase the awareness on the consequences both of menopause if it is not properly treated, and on the risk of not being followed up. I think we should work on this, on raising awareness of the entire population on this particular issue, because it is a very, very important issue for the generations to come. Because we live longer, but we should live also a good life. And that's why to start the right MHT at the proper time can help in increasing the health span. So this is one of our priorities, I think.
Sure. I think that's why we are even bringing this menopause related discussions back and forth into our audience, because that population is now growing and we need to sensitize both the providers and the healthcare seekers towards that. One last question, Kera. What is the must do investigations, the shortest list before you start MHT with confidence? Because this whole thing is about what will build your confidence to prescribe MHT. Are we missing something? Have we not done this investigation? Because we can't afford it all. So if you have to give just 4 bullet points, you do this, 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 this. And if this is okay, you're good to go with the menopause. Can it happen like that? Is it so easy?
If I had to choose 4, I would choose mammography and ultrasound of the breast. Second, transvaginal pelvic ultrasound, blood pressure measurement, and of course, blood test to check whether she has some problems with her lipids, glucose, and so forth. And of course, the heart should also be checked, at least from her own history. So we should take the personal history as something crucial to decide whether to proceed with more exams or not. So personal history is crucial. And also family history, and personal history.
So I think resource constraints will not stop us from taking elaborate histories. That is something which we should and we can do.
Exactly.
So the minimal investigation. One last question by Dr. Suchitra Pandit. Can you voice your question out, Suchitra? She is our distinguished panelist, and after her key question, we will let you go. Kira.
Yes, thank you for highlighting all those wonderful points where there was a little query. I just wanted to check with you. When you're using transvaginal estrogen, you said that the problems are much lesser than the oral, which I agree with. But what if the woman has an intact uterus? Because in that case, you'll have to use a progestogen for the last 12 to 14 days. So would that have an impact on how the side effects are? Would it change, or the type of progesterone at that time, would that matter?
Well, from what I understood, you are asking whether with vaginal therapies we need to add progestogens. Is that the...
Yes, if there is an intact uterus, you have to add, right?
As a matter of fact, even in women with an intact uterus, you don't need to add progestogen if you use vaginal preparations. Of course, you don't give a vaginal preparation every day. Usually, for maintenance, you use a vaginal preparation twice a week. And by doing this, and of course by reassessing the patient, if her endometrium is still thin, you don't need to add any progestogens. But of course, we know that the individual reactivity counts. That's why to be reassessed, to be followed up is essential. Yeah. But usually, if you just give it twice a week, you don't need to add progestogens.
Okay. Thank you so much.
Thank you, Kiera. And we will take rest of the questions in Manjula's panel, unless by mistake, if Uha has raised a hand, or do you really want to ask something, Uha?
No, no, I do have a question,
Yeah.
if
Kiera, if you
possible.
don't mind, one last.
Yeah, one last. So while I was actually reading up for this session, I came across research that said that in the process of HRT, while that is going on, especially in the initial stages, there is an increased risk for suicide. So this is from the mental health perspective. I have my own theories as to why that might be so, but I just wanted to pick your brain on has this been something that you've observed in your experience?
Well, absolutely not. In fact, usually MHT is also very good for mood, in case of depression and so forth. And depression and mood problems, mood swings are very common after menopause. And MHT can decrease this type of problems. So it's another way to to prevent problems connected to depression.
Of course. Thank you.
Yeah, excellent. So I think we'll really keep to now our promise of letting Kiera go because there was some miscalculation in the timing on her end. Otherwise, she was going to stay longer. But so thank you so very much, Kiera, for this wonderful deliberation. And there are a couple of more questions which will be directed by the panel moderator to the rest of us who are in the panel. So we do hope that at the FIGO Cape Town, we will get to meet Kiera in person and discuss more. And of course, we will bring her forth for a couple of other knowledge cafes through our own connects as we move along in future, doing more and more for this very special age group of menopause. Thank you so very much, Kiera.
It was a pleasure being with you.
Thank
Bye.
you. Bye-bye. Over to Dr. Puri now.
A very good evening. And before we move on to the panel, this is an announcement and a reminder of another mega event being organized by Artist for Her. This is the Cutting Edge 2025 Discuss, Debate and Decide Innovation to Implementation being organized in Bengaluru on the 14th or 15th instant, that is August. We hope to see many of you there shortly. We now move on to the panel discussion. This panel is going to be integrated approaches to menopause management from hormones to holistics and is being moderated by Padma Shri Dr. Manjula Anagani. Let me first introduce the moderator to you all.
The less said, the better. I think we will not waste time on introducing.
Not much, ma'am. We know a lot about you already, so I'll keep it brief. So Padma Shri Dr. Manjula Anagani is the Clinical Director and HOD Care, Vatsalya Women and Child Institute, Care Hospital, Hyderabad and Aditya Hospital, Hyderabad. She's the Guinness record holder for highest number of fibroids removed from a single patient. And she's performed the first gynec robotic surgery in Asia Pacific. She's the Indian of the Year 2015 award recipient. She's received many healthcare excellence awards, many lifetime achievements awards, and she's the founder secretary, Society of Ovarian Rejuvenation. The first of our panelists is none other than Dr. Hema Divakar. She's already been introduced to you all. As I was reading out the awards that Dr. Manjula has received, let me just mention a few of the multiple awards that Dr. Hema has received. She's the FIGO Women Achievers Award 2015, Global Asian of the Year 2018, CME Excellence Award for Artists, and the CSR Impact Award for Divakar Service Trust. We move on to the next panelist for the day, Dr. Anju Soni. She's Vice President FOXY 2026, President Indian Menopause Society 2024-25, Vice President Endometriosis Society of India 25-27. She too has many awards to her name. To name a few, IOG Excellence Award 2024, Illuminous Alumni Award by Chief Minister of Rajasthan in 2023, Chikitsa Vibhushan Award by Health Minister of Rajasthan, and she is the Wonder Woman Foxy Award recipient. Dr. Professor Suchitra Pandit is our next panelist. She's a Foxy representative to SAFOG 2024-26, Associate Member FIGO Ethics Committee 2023-25, Co-Chair NDC Committee SAFOG 2024-26, International Representative of Organization Gestosis. She is the President Gestosis India Association 2016-23. She was President of Foxy and ICOG 2014 and 15, President Mumbai Society of OBGYN 2013 and 14. To name a few of her awards, she was the winner of Lord of Planets Award UK, FIGO Women's Award 2018, MMC Award 2016, Honorary Fellowship of Nepal Society, Moggs Dr. Desai Award for Excellence, Moggs Dr. Patki Award for Think Global, Be Local, Foxy. Foxy Best Committee and Publication Awards, Foxy Dr. Durusha and Moggs Ganatra Committee Service Award. The last but not the least on our panel is Dr. Uha Susmita. She's the founder and consultant neuropsychiatrist, Sai Sutram Mental Health, consultant psychiatrist, TMS Mindspace Bengaluru. Some of her publications have been mentioned here. Impact of stressful life events in mood disorders, socio-demographic characteristics and aggression quotient among children in conflict with the law of India, a case-controlled study, basal ganglia calcification presenting on psychosis, cross-sectional assessment of empathy among undergraduates from a medical college in India. She's an active member of Student Society, Scientific Society from 2009 to 2014 at the AFMC, and member of student editorial team for Indian Journal of Scientific Research. Over to you, Dr. Manju.
Thank you, Dr. Purni, and thank you, artist and Farmed, for giving this fantastic topic for us. And I hope I'm able to share and you all are able to see this. Right, now let me make it a full screen. Yeah, even though it's going to be the hormones to holistics, that is what I have put it, not holistic to hormones. So this is something which we all feel. I know Dr. Uha can see how burnout of gynecologists happen, especially now that life expectancy has increased and half the patients are living more than 30 years in menopause. And it is always like, career mistakes. Are we here to listen to all these problems? Do we have a solution? And somebody will come up with Google knowledge and keep telling us, doctor, I heard about the ovarian cancer research. My cardiologist told don't take. And somebody said it is not good. But I'm having these problems. That's when we think that, so to give them the right knowledge, right to people is something which is very important. But are we able to give it to them? What is the Google confusing them? And do we have enough time to give them the right information? For that, do we have the right information is where it is. So prevention begins where preparation meets knowledge, that we all know. And menopause is our battlefield today. So we had a fantastic lecture, and then following which we are going to talk about it. And is it the time for change for us gynecologists to give them the MHT or additional non-hormonal when the patient do not want it? And the measure of intelligence is the ability to change. So first I thought, let me go through little things about menopause, and then we get our panelists to answer questions. Menopause, we know it's 1 year, retrospective diagnosis, no ovarian follicles, hormones come down, and most of the patients get confused whether it is absence of periods or whether it is hormones, and no independent biological markers, even though we look at FSH as one of it, and objective sensitive marker is definitely regular cycles. But we don't have to do routinely to diagnose. Just a year of this thing is enough. Some definitions we talk about is menopause, early menopause, premature ovarian insufficiency, perimenopause around 1 year around it, postmenopause after 1 year around it. The impact, why we are all talking today, is it is multifaceted, physical, emotional, psychological, and social. And for hormone therapy to holistic healing, how do we actually personalize the menopause management? To talk about it and to answer questions, we have my good friends, Dr. Hema, Dr. Suchitra Pandit, Dr. Anjusuni, and the newfound friend, Dr. Uha Susmita. So my first question, I'm sure one of you would be taking it, and I think after the lecture, it is much more easy for her to go. Dr. Hema, is how do you actually understand menopause? Overview of the changes, and what are the common symptoms and importance of individualized hormone assessment should we do? And before we target them for this treatment, or generally you have some nomogram to just put chapamar treatment?
Okay. Thanks, Manjula. Thanks all the panelists for being on the event today. See, usually about a decade ago, women in this age group used to only come to quick fix their menstrual problems. That was the only thing that would bring them to us largely. But now the trend is changing because the perimenopausal age group, the moment they start getting hot flushes, mood swings, palpitations, they're kind of, as you mentioned, Dr. Google, they're kind of aware of all these tidbits of fragmented information, and they also mention these in any of the visits, which may be for other reasons too. And some of them will worry when the cycles get a little delayed or these vasomotor symptoms start 2 3 years ahead of menopause, that am I already, at 40 or 42,
Yeah.
am I already becoming menopausal, and this and that. And then hair loss and has been and the dry skin and dyspareunia, and also they're so psyched up with the stress at office and the time that they may have with the husband or the partner. It's very, very, and then the forgetfulness, the children are constantly blaming them for this, that, and the other, because they are not able to take the decisions, or they are forgetting, and they are screaming at everybody in the family, etc. So all these things are a large part of the discussion when the women comes to us. So as Kara also rightly mentioned, and you also said in the beginning, there is no need for us to do any of these tests. Just get at the history of when was the last menstrual period, and that makes that is the chap or the stamp that we have to put. Though perimenopausal brings with it all of these hormones, and the worst thing is that she can't remember, because even before her cycles were a little irregular, 1 year, 2 months, and then one spotting. So is it postmenopausal bleeding? Is it not? So that is the kind of worry that sometimes we as clinicians face in the gray zone, as to call it. So most of these are documented in all the tertiary care centers and hi-fi settings, and sometimes patient gets it done on her own and comes to us with the reports. All these things are common, scenarios in our practice as on today in the metros.
My question to you would be, in the postmenopausal bleeding, the patient had, like you said, she doesn't remember whether it's 1 year or 10 months, and she comes with a bleeding. So would you do a FSH to confirm it's postmenopausal bleeding, or you would wait for her to have another period before you think it is something like that?
We may not. First of all, we will say, when did that happen? Because some will come one spotting trace, when I wiped it came, and this, that. She's also not very sure whether it is post-intercourse, or it is vaginal dryness, or whether it is rectal bleeding. These kind of situations are also there. So the intensity of how much she has bled, and also whether the bleeding has occurred more than once, is something that we would always want to make a note of. And yes, if we want to prove that it's menopausal, then serum FSH, if it is
because ultrasound says endometrium is 8 mm. Now we know menopause means it is 4 mm and less, and 8 mm definitely is abnormal for postmenopausal, but it is normal for perimenopausal.
Yeah, we could add on this serum FSH just to corroborate.
Yes.
Yeah, that's just, it's an additional finding, but when we look at the patient and we want to do something to her, there are many other factors which we have to take into consideration to see what is the next best action step. Yeah.
Perfect.
Anju, I think Anju wants to say something. Anju?
Can I? Yeah, I want to say something.
Yes, Dr. Anju.
Yeah, for diagnosing menopause, we do not need to do FSH, LH, or AMH.
Right.
It's very clear. It's a message I want to give to everybody who's attending the session, that we do not need to do any of these tests, FHS, LH, or AMH, to diagnose the menopause.
Yeah, this is a
only a
postmenopausal
diagnosis.
Absolutely. Dr. Anju well said, we are not doing it, but that is the reason I said it is individualized hormonal assessment depending on the case.
Yeah.
If it is reproductive part, she is having early menopause, yes. But to diagnose menopause, we do not.
The postmenopausal bleeding was the question, Anju. Because the initial question was, would you do any tests? We said no, go by the history. Yeah.
The next question was, if the patient has forgotten the date of menopause, and if she is not very sure, if she has a bleeding and endometrium shows 8 mm, would you do any tests? Okay, and I think it has to be realized, and we do FSH to confirm, then take a call. Right.
Manjula,
Yes,
Can
ma'am.
I just say something?
Yes,
See,
ma'am.
since you're saying you've already done a TVS, I would also ask you, how are the ovaries looking?
Yeah, ovaries are
Was the
normal. Ovaries
Are
are
they normal? Yeah, fine. Otherwise, you're always,
small
you're
sized,
always
small sized.
yes, fine, perfectly fine. But I would look at this as a time for an opportunistic screening for the patient. Maybe
Absolutely.
she's never ever been to any health consultant and she's just worried about the bleeding. So this I would like to take as a window of opportunity to screen for, though I'm not doing test to diagnose menopause, I may do a battery of tests just for her well-being.
Right.
Like the
Absolutely.
sugars or the
Yeah,
lipids and the
everything.
mammos.
Yeah. Yeah. Thank you, madam. And this question is coming back to you, Dr. Suchitra. When should the
Yeah.
HRT be initiated or avoided? This is something which Dr. We had right now the lecture, and what are the risks and benefits, just as a brush up.
Yes. See, first of all, I think when a woman like this comes to me, I would go into a detailed history looking at her, Harris factors, family histories of any cancers. I would assess what her symptom profiles are apart from just bleeding. Does she have anything else? What is the severity of the symptoms? Does she have any vasomotor symptoms? Does she have any vaginal dryness? The standard symptoms which are there of menopause. And
Mhm.
then I would sort of do an investigative approach, and along with that counselor find out what she exactly wants, and if the quality of life quotient is being affected by this. Now in this case, there is bleeding, she's going to be worried about it, but is there anything else that worries of her? And then decide about the treatment factors. And yes, since you're saying the TVS is done, and in this particular case it's less than 4 millimeters, I'm not terribly worried, because I know that this could be just one off. Because though we know that menopause, 12 months of no periods, you could have one of those ovarian follicles just getting ready.
Yeah. Yeah.
There's a possible,
Perimenopause.
and
Yeah.
that can just lead to a little bit of a bleed. So I would counsel her, but this is a time I would also probably, before I take on any steps for treatment, I would do, I would actually do an upper abdominal scan, also look at the gallbladder, look at the other organs, do a mammo, because mammo is something which is being missed in our women, though we know that the incidence of breast cancer is very high. So this is one mammo plus sonography that I would definitely do. And then I would discuss about the treatment aspects with her. Manjula, another thing which I'd like to say is, in this particular age group, the incidence of iron deficiency is also very, very high, because we had a recent paper suggesting that.
Right.
And we would also look at, the vitamin D3, vitamin B12. We don't need to do investigations, but, we can start looking at that aspect and then tailor an approach. And yes, I would ask her, how are you feeling about it? If the quality of life is being affected, I would definitely counsel her, because if she's 49, there are definite advantages of giving MHT, because today the current studies and, the previous lecturers also pointed out very nicely to the fact that MHT, if it is started at the right time, the
Mm.
benefits outweigh the risks, and it improves the quality of life. It gives a protection to the heart, it gives a protection to the bones, and it also confers an important effect on the lipid profile, and tells, like sort of helps her to reshape her body fat. So all these advantages are definitely there. And though there is no direct evidence, I think the incidence of Alzheimer's, we don't have a strong link to suggest, but if this is started in time, probably the cognitive behavior is also improving. So I
Yeah.
would definitely offer it to her. I would dispel her fears, because most of them are worried. The biggest worry they're worried about is, will I continue to have bleeding all the time? And two is, will I have breast cancer? So
Right.
once I've discussed this with her, I will, give her the different forms available, and definitely. But, along with this, lifestyle changes.
Right.
Whether her life is a sedentary, housewives tend to do the housework, but they are not doing additional exercises. Whereas women who are going to the office are all stressed out, and they're just running from the office back and forth, driving cars or coming by trains or whatever. So I would like to add on that quotient of lifestyle changes, which includes a good amount of dietary advice, including fresh fruit,
We'll come to
vegetables, and
lifestyle
exercise.
afterwards. My
Okay,
question
great.
again, Dr. Anju, to you directly is, in a nutshell, I just want you to divide the MHT into when uterus is present, when uterus is absent. What do you choose depending on the patient profile?
First of all, Dr. Suchitra has really pointed out a very good thing, that we must screen all the women for any comorbidities
Right.
which
Right.
she may have, number one.
Mm.
Number two, we need to, I will clarify here, we need to give MHT to only women who are suffering from hot flashes.
Yeah.
And it is indicated in that case, and also for this vaginal or genitourinary problems. For that, we will be giving local only. And systemic at the moment is only indicated for hot flashes. Nothing else has been said except for Australia and India, where we are giving MHT for osteoporosis also, because it has a very beneficial effect for osteoporosis. Though when we give MHT for these conditions, patient gets benefit for cardiovascular diseases also, prevention for diabetes also, for mood and for fog in the brain also. It's beneficial for everything. One more thing before going to your question, I would like to stress here is that if in India the average age of menopause is 46.7 years, 5 years, and in Western countries it is 51 years. So in our country, when we go 2 SD down, the early menopause starts at the age of 40 plus to 46.5, and POI, premature ovarian insufficiency, starts from the age of 38. So all these women have to be given hormone replacement therapy. Now your question that if a patient has a uterus, then we must give her estrogen, and that estrogen has to the endometrial proliferation has to be neutralized with the progesterone. And that progesterone can be given orally in the form of gel or in the form of LN-UIG. And in form of oral, we can give dihydroestrone or micronized, the natural form of progesterone. That is the most effective and the best. And we have to start with a minimal dose of both the hormones, estrogen as well as progesterone, and then increase the dose as and when required according to the need of the patient if the patient is not effective. As far as the genitourinary symptoms are concerned, we only need to give her a local estrogen therapy, which is available in the form of creams, tablets, and rings, which are not available in our country. But when we give in the minimal dose, which is prescribed for local dose, we do not need to give any progesterones, and it has been scientifically proved that when we give in a minimal dose, the serum estradiol levels are as low as the levels of not giving any estrogen preparation. So there is no risk. It can be easily prescribed in malignancies too.
So my point is, like, I would actually answer it this way. The point is, when uterus is not there, I would give only estrogen. When uterus is there, I have a choice.
I told you, when uterus is there, we give estrogen and progesterone both. But when uterus is not there, we only give estrogen because we are not worried about the
When do you
estrogen.
choose Tibolone? When do you use Tibolone?
So it has basically, Tibolone has got a lot of benefits. It has both estrogenic and non-estrogenic effect, and we do not need to.
All that, Dr. Anju, everybody, I just want one line answer. That's it. With estrogen, if uterus is not there, I would give estrogen.
Tibolone can be given. It is very beneficial because we do not have to supplement with progesterone, number one. And number two, it is also beneficial for the libido in the woman.
So I would put it in this way. If the patient does not have the other thing like a lipid profile abnormalities or even liver or anything, my first drug of choice would be Tibolone if uterus is there. And then I would go for E plus P if the patient, especially if the patient does not want bleeding or intermittent spotting.
And Tibolone can only be started after 2 years of menopause, not before that.
The perimenopause also, nowadays people are giving Tibolone.
But as till date, the scientific evidence says it has to be started 2 years after menopause.
Right. But anyway, so now we have 3 options, like our panelists have told. If uterus is there, then you have it's only local symptoms. You can have only estrogen twice a week. That is the first answer. Second, if uterus is there, it can be E plus P, low dose, lowest dose to be started off. Then either in the form of intrauterine Mirena plus estrogen, or you can go for Tibolone. If uterus is not there, life is very simple. We give only estrogen. But still, again, if the patient have thrombogenic or other thing, then you can just give non-hormonal treatments so that we do not give any of none of these contracts.
If patient has this problem, DVT or not, we can give them sprays or gels or patches.
That's it. Okay.
We have to avoid the oral because the metabolism of estrogen is through the liver, so we have to avoid it.
Yeah. Coming back full round, I know Dr. Uha, you must be thinking I will not include you, but your questions are waiting in the line. But you can jot in an answer anytime you want to answer. Dr. Hema, one thing, guidelines, so many guidelines confusing everybody. So what do you say about these guidelines?
Actually, my honest opinion would be, Manjula, whatever the guidelines say, it is not getting translated into practice for sure. Because there are volumes of patients who may deserve the explanations, the investigations, and you want to put them on MHT at some point in time or the other. But the prevalence of use of MHT is minuscule compared to the millions of population that we have. Because the moment we mentioned, that's why I raised my hand for two important points. One is the wheel of wellness, which Kiara also referred to. That is the prevention and wellness care of the women. Wherever in that point she enters, you do multiple things in an integrated approach. So, like when she enters into menopause, all the NCDs and everything needs to be tackled. That is the very, very important point. Don't miss the opportunity to do more than fixing the specific problems of menopause. The second thing is hot flushes, yes, because it bothers her. And Anju said only if there are hot flushes, then you give the MHT. But actually, for hot flushes, women prefer taking non-hormonal because it works like magic in many cases. As long as they're rid of the hot flushes, they're quite happy. So this large segment of the women in the country are happy not taking MHT but taking the non-hormonal treatment. And then there are other factors like fatigue and also new concepts of magnesium for the muscle health, for example, because we are talking always on bone health and blood health. That is anemia and osteoporosis. But there are muscles also. The muscle weakness, then the magnesium comes. And from UHA and other psychiatrists, we always constantly have the magnesium vitamin D combinations, because then sleep disturbances and some things to do. Oh, my psychologist or psychiatrist has already told me to take that. That opened our eyes into, oh, maybe this has more role to play, etc., etc. So this is the actual practical scenario, irrespective of whatever the guidelines are saying, Manjula. That is
I
my
totally
honest
agree.
answer.
So strong evidence definitely says non-hormonal therapies like gabapentin, SSRIs, SNRIs are equally effective. Rest all will be inconsistent evidence and
No,
levels.
now there are non-hormonal other drugs like in India also available. NK3 antagonists are available in India. Fezolitant and all that, they're very, very good.
Yeah, Rankle and
So
all.
we can give that also as non-hormonal.
I just like to mention that though gabapentin is being prescribed, the side effects are not really, the risks are too high because the
Madam, dose
gabapentin
is important, madam. 100 milligram TID does not have so much dose. If you give 400 TID, yes, 100 TID for 2 months.
Dr. Suchitra is absolutely right. There is a lot of sedation and other problems. So now they are not recommending gabapentin.
Madam, dose is very important in that. So,
Ma'am, if you're talking about
in 2022, there is a recent white paper was released at Portugal in International Menopause, and they clearly said that we should not give these drugs, and MHT should be the first option always.
Yeah.
I do agree with what Anju is saying, that MHT is preferred rather than gabapentin. Only if there's a contraindication to MHT do we we would go in for the gabapentin. And as you very rightly said, low dose, but that dose should be tapered on over a period of time.
Okay.
Ma'am, if you're talking about non-hormonal treatments, the first line is always every paper says MHT. If the patient is amenable to MHT, that's always first line.
Right.
If the patient is non-amenable, then rather than gabapentin, I would agree. SNRIs have shown much better results if you're going with venlafaxine, desvenlafaxine, even more than SSRIs actually. And given any medication that is targeting CNS, obviously we'll go with very slow titration, especially when the lady is already going through a transitional phase and experiencing a lot of troubles in a lot of ways. So we want to keep the side effects to the minimum. So always slow, start low, go slow. That principle anyway applies. And the second point is there's been a lot of research that says the harder the transition, the more difficult are the mental health struggles. There's a very strong correlation over there. So whatever the patient is amenable to, I would say let's just get started to make the transition an easier time for the patient. I think that
totally
should be
agree,
priority.
and I think it is
There are NK3 receptors which have been recently launched, which the studies which have been approved for British and Australia and UK. They have been proved to be very good for all the patients, like Fezolinetant, which is available in India also.
Mhm.
So it's a very, very good drug, and the effect starts within a week time. And within 4 weeks, the patient is completely relieved from severe hot hot flushes. And it is a good, very good alternative for non-hormonal prescription than SNRIs and SSRIs.
Wonderful.
So
I think
I
more
would
should
prefer
be,
to give that treatment if possible to the patient if patient does not want to go for MHT.
I think we'll just wait for that product to be available to us so that we
It is
can.
available. It is available.
MK3. Okay.
Yeah.
Yeah, it's not freely available everywhere. It is
Yeah,
come in, but it is
yeah.
not easily accessible for everybody.
Wonderful. I think we will look
It is
into.
little expensive at Dr. Suchitra, but it is clearly available. We can always get it.
Okay.
Tell the pharma people to give it. They supply you directly also.
So to put it in a nutshell, MHT is the most effective. It should be individualized and lowest effective dose. No mandatory limit to the duration. Everything should be about benefit risk ratio, like Kiara has told. Annual reviews are essential. Then monitoring and follow up. This is a question which even Dr. Hema asked Kiara. So one of you just tell me how should be the monitoring be there?
So
On
usually,
HRT. When
can
women
I
are
take
on
it?
HRT.
Yeah.
Okay. So usually when I start off with MHT, I've counseled them. I tell them to come back 1 month later because I want to know whether they've actually taken it correctly, how are the periods, how have they responded, whether there are any side effects. And typically, initially they do have some nausea, some breast pain. So though I've counseled them, I'd like them to come back a month later. If all is well, then I call them back 3 months later and then once in 6 months. Annual follow-up seems to me a little difficult. So I prefer to call them once every 6 months. But when I'm calling them before I started the MHT, I've done all the investigations. And usually I would tell them once a year, it is always advisable to do a mammo and a sono. And, some of the blood levels, which we do it for the routine patients also, like the sugars and lipids, I'd like them to definitely do it. And
LFTs.
and the LFTs, absolutely, the LFTs and the lipids. And one more thing is, I do tell them that in case they feel some problem, something that is untoward, then they have to come back and ask me. I just wanted to mention over here again, when if you are starting MHT in a perimenopausal or an early menopausal period, or when the patient is not yet completely fully menopausal, she accepts a period. But in the postmenopausal period, we have to tell them that if they start spotting, there's nothing to worry. Usually with a continuous combined MHT, they will have spotting for the first 3 to 4 months, but gradually it peters off. But if they have a sudden gush of blood, they should report to us immediately. So
When
that
do
is the
you,
way I would tell them to
yeah,
come.
when do you do a bone mineral density? Do you do it? You don't do it? And how do you do it around
Yeah,
menopause?
I think it's excellent question. A BMD, I wouldn't do it for all women unless they are 5 years post-menopause. But before 5 years post-menopause, if they've got some high-risk factors, like they've had autoimmune diseases where they've been put on steroids, or they've had, a history of a premature ovarian insufficiency, or some kind of a treatment where they were deprived of the hormones,
Cooking
like
also.
they've had a endometriosis surgery or something like that, where the ovarian hormones have petered and they've had a menopause, say at 42, 43. In those cases, probably I would ask for a BMD. And also, if there is a family history of osteoporosis, and if the woman has had maybe a fracture, where you can't explain why that has happened, in those cases, I would definitely do it. And continuous backaches, women do complain of that low backache all the time.
True.
In those cases, probably I would be more inclined to do
I think
BMD.
that covers everybody who is having in the menopause. I think nowadays we know with the whole India as a nation are becoming thinner and fitness freaks, and definitely bone osteoporosis is higher. And with IVF treatments and lot of ovarian cycles and premature ovarian failures, BMD
Absolutely.
has started coming down.
So,
Thank you
Manjula,
all.
Manjula, in our wheel of wellness, Manjula, in a wheel of wellness, that bone health is given enough importance because
Yes,
if they're osteopenic and we recognize it earlier, there are a lot
yes.
of
I
advice in
would
a
prefer
preventive
to do
manner we can give. So,
I
we want to do that as a part
earlier.
of wellness program, actually.
Yes,
Hmm.
yes. I would not wait 5 years. I would do earlier because of all these things what I said.
Especially if a woman is a smoker, also you should do it
If there
early.
is time,
History
all
of
those.
fracture in the family or herself
Yeah.
is
Now
also a higher risk case.
Let us go to the second segment of my questions, that is mental health
Uh,
and emotional transitions. And
Dr.
Uha,
Manjula,
yes,
can I just add one point regarding the
yes,
follow-up aspect? So
yes,
this is in tandem with the point that I had raised earlier, the question that I had asked.
yeah,
So the paradoxical effect that we see in depression, it's a fun fact, not so fun though, that as depression comes down, let's say that a patient was severely depressed, and now after treatment, they've gone down to mild to moderate depression. The
right,
risk of completed suicide is higher when the depression has actually come down
right,
in the mild to moderate phase. So similarly, when the patient is started on MHT and they're getting better, but they're not completely better in the
yeah,
in-between phase. So during the early follow-up, I would recommend doing an assessment for their mental health as well as the suicidal risk in case the patient has
right.
mentioned it
This is
earlier,
the whole,
because
that
the
is the
risk
whole,
of completed suicide gets higher here
I
because
agree.
they
The
have
whole
regained
segment
their
is only
energy.
going to cover that. And I
Yes.
also wanted to tell you that in today's time, where it is one child and two child and then empty nest syndrome coming in the same time, I think we should look at the external factors along with menopause, adding to the whole compendium of this depression. Anyway, let us now talk about it. The psychological impact, stigma and silence around menopause, to come to the doctor and talk about it, and the role of cognitive behavioral therapy and mindfulness in support kits. These are three things which I wanted to talk. So, Dr. Oha, what do you think about these 3 points?
So to talk about psychological impact, I think there are three main aspects. One is anxiety, the other is depression. We can put both of them under the major umbrella of mood swings. And the second I would talk about is sleep disturbances, which contribute and create this vicious cycle. And the third thing that I would talk about are the psychosocial factors, which again keep this wheel turning,
Mm,
right?
mm,
The psychosocial factors, one of the most important things is what is actually on the screen here, the stigma that is associated with
right,
menopause and in general the hormonal health about women. We don't discuss it. It's not a dinner table conversation. It's not knowledge that is passed on from
right,
mother to daughter in most homes. It's what we figure out as we go along. So a lot of times when a lady in the menopausal age range demographic comes to me and they're complaining about a lot of changes,
do
that
you,
okay, I'm just not able to keep up, I
right.
am not able to do the things that I used to be able to do, I'm always fatigued, and I don't seem to be able to sleep. I have no problems, my life is good, I'm comfortable, but still I feel like something is wrong. I think that is where the conversation about
I would
menopause
ask you
needs to
one
happen.
question here,
Yes,
Dr.
please.
Uha. Do you see patients who say that I'm not taken seriously when they put everything on my menopause? They say, oh, she's gone cranky. It's because of menopause. See, whatever point I want to put across, I'm not taken seriously and they want to put it on menopause. Is this one of the complaint which you hear? Because I do hear that.
Actually, yes, very much. So, if you're talking about, so funnily enough, again, if you're talking about people who've never talked about hormonal health, then the talk about
Right,
menopause never comes, right? It's just women.
right.
But if you're talking about educated people,
Mhm.
but who without the full understanding, then it's very easy to attribute everything to a woman's hormones. And
Right,
we see this silence being perpetuated, especially, I would say, in the working women, in the corporate structure, because in case you want to express that you're struggling because your biology is putting you in a fix, then immediately you're afraid of what you'll get in return, that oh, women and their hormones, so you might lose out on promotions, you might lose out on projects, you might lose out on giving getting a seat at the table, basically. So this is something which silences a lot of women from just accepting that they're struggling.
right,
And half the time they come to the doctor when things are very severe, when they've
right,
come to a point where I'm not able to function anymore,
right. They are
so
silent
I'm here now,
and more
just make
depressed.
me function.
Right. They are silent and then they become more depressed.
Yes, absolutely, absolutely.
What do you think is the role of cognitive behavior therapy, mindfulness, support groups, which are increasing more
Yes.
and more?
So, CBT has an amazing intervention, especially for sleep, funnily enough. So, the easiest thing to fix, I always tell my patients, is sleep, because we have so many medications to help with sleep. But if
Right.
you're looking at a long-term solution, then actually CBT is the first line treatment. So, there is CBT approaches specifically for insomnia that we can address,
Hmm.
uh, as well as addressing the points that we were just discussing about
Right.
the stigma, about what their perception of this life side, this part of their life is. How do they think their life is going to change, and what is the anxieties or fears that they're attaching to this, how that might be affecting their behavior. That's where CBT approaches play a role. And obviously, mindfulness is something that I think we should be incorporating way before menopause in general every day. So now that, okay, we are at menopause and the struggle is real, I think that is where taking half an hour out of your day just to indulge in some mindfulness based activity, it makes a lot of difference in the long run. You might not see results maybe in the first week, but at the end of first month, I have a lot of people coming back and telling me I look forward to that half an hour,
That's
right? Because that's
so
a fascia.
what would be your advice to your clinician friends how to integrate mental health screening into menopause care? And like
Yes.
you said, mood disorders are underdiagnosed. So why do you think so?
It's I think it's very natural for a lot of us to focus more on our physical symptoms, the somatic side of things, because we have this entire gamut called psychosomatic symptoms, right? Because
Right.
it's much more, pain is an acceptable expression. Physical pain is an acceptable expression, but not emotional pain. Emotional pain can be dismissed very easily because it's not something that you see, it's not something that's reflected on a report.
True.
So, in a lot of times, when a lady comes to me, regardless of menopause, it's easier for them to say, oh, I have a lot of headache, I feel chest pain, than for them to tell me, I feel anxious or I'm feeling very depressed in my day to day life. So, that has to be teased up.
Right.
So again, that translates again into medical practice because we are all people as well. We are all from the same community, from the same society. So
Right.
even for us as doctors, I think we need to overcome our own prejudices, our own biases, to look beyond what the patient is telling us and look at them fully as a person who's functioning in a society.
Right.
Secondly, how to integrate that practice into our day-to-day into menopausal care. There are very simple screening tools that we can use. There's something called PHQ-9, which screens for depression. There is GAD-7, which screens for anxiety. These are like 9 questions, 7 questions, very simple questions. These are answerable. So the patient self.
Are they same that we use for the perinatal health also?
Yes, yes.
Okay.
So for perinatal health, ma'am, there are quite a lot of scales which have been developed specifically if you're looking at postpartum, right? There are
But
specific
the
scales for
ones you
that, but
mentioned is
yes.
now integrated into our course. That's why I'm asking.
Yes, yes, absolutely. These can be integrated at any point in life. Perinatal, we can use PHQ-9 and GAD-7. Menopausal, we can use PHQ-9 and GAD-7. These can be taken directly by the patient. We can just give it to them in the waiting while they're in the waiting area, and they just answer the questionnaire and give it back to us. Very simple scoring. So it's just screening for us to separate out the patient who require a little bit of extra attention.
Right. So
That's
that
all.
we can when to
Yeah.
when to refer to a psychiatrist when only empathy works. That is a differentiation which these people when the friend group work.
Yes.
So that is something
Yes.
very, very important.
Manjula,
Yes, ma'am.
I just want to just make one more note over here is, when there are younger people seeing patients, they tend to brush all these patients off as, it's okay, it's menopause, just go away, it's okay.
Right.
So I think for them that screening tool will help. But
Yeah.
someone at a senior level, what I have noticed is women who've had a stormy post-delivery period, they've had postpartum depression or some
They
kind
have
of a
more
problem.
chances.
Anxiety. These
Yes.
Right.
are the ones typically, their anxiety gets more unmasked at menopause, and then they haven't taken treatment before, and now this is a time when we should be able to refer them. But whenever you refer them, many a times they start thinking, oh, then they say, doctor, do you think I
Don't
really
want
have a
to.
problem? That
Right.
stigma, so that's why we'll have
Stigma.
to tell them that it's not a stigma, it's just that it'll help you. So I think here again the counseling and referral to a psychiatrist is very important. And I think not all psychiatrists, but someone like who are sensitive to these
Yes.
particular issues.
Very well said,
That's
Madam.
yes, that's a very beautiful point, Dr. Suchitra, because you brought forward a very important risk factor. Any patient who's already gone through some mental health struggles, they had diagnosed clinical depression, they had diagnosed anxiety, they suffered perinatal issues, they are
Yeah.
at a much higher risk of developing issues in the perimenopausal period as well. So that's already a risk factor that they're undergoing. Family history again matters. The same history that we always take, these things stand out, right?
Yeah.
So if we are talking about referral, I would say anybody who falls into, if you're talking about screening tools, anybody who falls into the severe category under the screening tools, that they would require a referral to the psychiatrist. Any patient where functionality has been grossly affected, they're just unable to get on with their day-to-day life, a referral is should be requested. Also, somebody again who has gross sleep disturbances, they are just unable to fall asleep despite doing, the nooks that we do, the hacks that we do. They are having chamomile tea, they're following sleep hygiene, everything they're doing right that they can do, but they're still not getting enough sleep. Then that should be referred to a psychiatrist. I think
Thank
these are
you.
points that
Yeah.
of the top.
So I think take home here is I do understand that time constraints are there in consultation. So the screening methods and in the lobby when they are waiting, filling it up. So for that, the poor awareness of patients and providers should take over, and then people have to be aware and decrease the cultural and social stigma. Thank you. Now comes Dr. Suchitra's question of what she wanted to say about diet, lifestyle, and physical activity. So, what are the anti-inflammatory fat diets which are coming now and bone-friendly diets which you recommend? And the importance of hydration, protein intake, avoiding ultra-processed foods, and what are the recommendations for
I
exercise?
think first of all, I would tell them drink lots of water. Many a times,
Yeah.
office going women tend to drink much less water. So it starts off with water at least 3 liters a day. And I would say include sunshine. They're moving in air conditioned cars, or they're working in an air conditioned office, or in the house, they're not getting out. So that fresh sunshine, and that comes with your either your walks, or I know the walks, early morning walks don't give you that sunshine. It's 11 o'clock walk, but at least if they get out in their way. So it starts with a brisk walk in the morning, some kind of an exercise when you're doing today. In many of the cities, they have these, the women groups who walk together in the morning, 6 to 7, and at the same time, they're doing their yogas and they're, singing or whatever, simple things. So that gives you a positive state of mind. And second is as you very rightly said, it should diet. If it's a normal woman who has got no diabetes, no, obesity, she's, in the normal state, and she's not having a normal thing, we would ask her to include a lot of fresh fruit, vegetables, because again, today, the young population, 10 years ago now, are all in their 40s. They tend to eat less of, veggies and less of fruits. They're hooked on to those fast foods. And that was a time when it came on, when they were young, and they're hooked on to that. So telling them to reduce the trans fat diet, telling them to include more of, a whole cereal food, and include the normal regular food which we cook at home, that would be much more better. Nuts and cereals and regular diet. And I would say one thing, this is a time to regularize the eating habits. And usually we are talking about eating food before 9 o'clock, so that you have at least 2 to 3 hours before you get to bed,
Right.
because having a late night meal can affect the liver. And NAFLD, the non-alcoholic fatty liver cirrhosis, is coming up in a big way in women where the BMI is higher.
Right.
And
So,
this is something which we have to look into. And importantly, is some kind of exercise for women who are, the sarcopenia is setting in,
yes,
particularly when 45 plus. So building up bone strength and muscle strength equally is very, very important. A
okay.
dose of vitamin D, calcium, importantly, and of course, if they're taking any of their other medications to revise. And
Yeah.
Manjula, I'd like to say here, sometimes they start off on a BP medication,
Yeah.
and once they started, they never go to the doctor for 6 years and 7 years.
True.
So whether the BP is right, wrong, so that is a time when you can give them these advices also. So go ahead, go to your physician, get your ECGs done, get your BPs in control, get your sugars in control. And today, a lot of the beautiful diets which have come up. Now, I'm not talking about the keto diets, but I think the low carb, high protein diet
I
helps a
think
lot.
we are having
Mediterranean
lots of
diet.
time constraints,
A
so may
lot
I
of
request
Mediterranean
you?
diet is in.
Right.
Mediterranean
Yes.
diet has been.
And
Yeah,
cutting
Dr.
out
Been.
on the
My
red meats.
question to
And
you, my
Yeah.
question to you is very specific. A lot of
yeah.
soya and plant-based estrogens are being used. So what is the what is it helpful or actually harmful when they are taken without anything? Because we have in India as a thing like fat, they take everything more, and then we end up having an endometrial thickness. So what exactly do you think, and what is a weight management play in symptom relief, lifestyle adjustments again?
So I think if you're going to give isoflavones, it has to be in a proper metered dose. You can't just keep on having that.
Mm.
And you, again, isoflavones are contraindicated if somebody who's got a thyroid problem. If somebody has got a history of a breast cancer, where they are HER2 positive or ERPR positives. So whoever takes any form of isoflavones, whether it's directly soya or edamames. I know they are a good source of protein,
Yeah.
but one has to weigh the pros and cons. So when you're talking about a weight management, I think if you're really worried about taking it, a good nutritionist will help you to calculate the exact thing. But if you're giving it for prevention of hot flushes, night sweats, and I think a single tablet a day is enough, not those two and three tablets in the day. So
And
that is
monitoring
something.
should still continue.
As per,
And
Most
I just want to
tablets.
say that as per the scientific data, black cosh or soya, they are not effective for any kind of hot flashes. So they should not be prescribed as alternative for as alternative therapy that has been proved by as science. And I just want to add that whenever you tell the patient about exercise, we must tell them to do a cardio of 150 minutes per week
Hmm.
and moderate. And if they are doing severe one, the heightened one, then they can do for 75 minutes, and that has to be supplemented with the strengthening of muscles
Okay,
by
in a
weight
nutshell,
bearing exercises.
yeah, in a nutshell,
Because
from
every
what the
patient comes
panelists
here, they would
told,
like to know how many minutes, what to be done.
yeah.
So we must tell
So
them.
from what my panelists have told, diet has to be well balanced, exercise is physical and weight bearing exercise. Weight management will definitely reduce the severity of hot flashes. Stress management
Not
is
only
very
hot flashes, it will improve your
bone
cardiac health,
strength.
it will
Yes.
improve your diabetic health, it will improve your
Smoking
bone health,
stress,
every health.
smoking
So weight
cessation, sleep
management is very
hygiene.
important even for the mental
Okay,
health.
I have rapid fire questions to you guys. So I just want to finish very fast. So you do have various complementary therapy, but in all this, I do want to talk about everything except one thing. What the supplements we talk about, we give a lot of, these are all the things which we spoke about. So magnesium, calcium, and vitamin D. So what is the role of magnesium, calcium, and vitamin D, and what is the dose you should give, and how long you should give? Should we continue to both for pain and sleep in perimenopause? One of the panelists can take it.
I think calcium, I would give 1 to 1.5 grams a day in two divided doses.
Right.
Calcium with magnesium is always better for the muscle cramps and building up the muscle strength. And vitamin D is 60K units per week for 3 months. And thereafter, maintenance dose of 60K units once a month for the entire year. So that would
Perfect.
be my take for this. And
Perfect.
drinking plenty of water.
Yeah. So
I would like to calculate what patient is taking orally as calcium and then give rest in two divided doses.
Okay, perfectly.
And we can
All of
supplement
you, all
vitamin
of
D
you
daily
agree,
also
all
and
three are
weekly
important.
also.
All of
We
you
can,
agree, all three are important.
yes,
Yeah,
Yeah.
most of the
all of
time
them
the
are important.
patient is taking it herself, Manjula.
Yeah.
When she comes, she's already ready. I'm taking this, that, and the other. And the
Absolutely.
self-testing of all these, the vitamin D levels and B12 have become a part and parcel of the master health check. So they'll all come with those. Oh, this is less. They'll only circle and come, and they're already taking. And then that is a proactive thing, which is good actually, because non-compliance of the patient is then not in the picture.
Right. So
Yeah.
at the
If we are
end of this
giving
panel,
magnesium for sleep, then 320 to 500 mg per day should be sufficient for
yeah.
sleep specifically.
Oh, magnesium 300 to 500 per day. Very good.
Yeah.
So in magnesium, the calcium, we always believe it is better to take in the night. So magnesium, do you believe to be given in the morning or the evening?
I think at night, because again, if there is any component of sedation associated with it, best to take it at
Muscle
night.
relaxation also works well.
Yes.
Thank you. To all my rapid fire is coming. After all this whole thing, do you still believe HRT is a gold standard? Yes or no?
Yes.
Yes.
Yes. So can holistic treatment replace, or do they best work together?
They work together best.
Very good.
Yes.
How do we train clinicians for integrative menopause care?
I
I
think,
think,
Yeah.
yeah, go
please
ahead.
go ahead, Dr. Suchitra.
No. When you're talking of the training the clinicians, it has to start right at the postgraduate level, teaching them, and the practicing gynecologists need to be told. I think prescribe with confidence, but prescribe after knowing what you're doing with the counseling.
So I
And the
think
integrated model of care, definitely, we can have small little workshops where you're talking to people and telling them exactly what you have to do,
yeah.
like a focus
Manjula?
group.
In fact,
Yes,
Yeah,
ma'am.
Manjula, my experience has been that one of the best cadre to be trained is the paramedical. The whole teams of nurses in the hospital, we have got huge experience with the Manyata training with safe delivery. Now we have extended it, like the scores which Uha mentioned, that they can easily be the facilitators for the kind of scores. And the nutrition aspect, we have coached them on the Anemia Mukta and Poshan Yukta Bharat. So they will nicely tell all the gaps, Figo nutrition checklist we use, and we tell. So there are a lot of points which they can plug in even ahead of the patient coming into the consultant's chamber, and they'll usually circle and send. So it becomes very easy for us. The time constraint is not a bother, and then this whole span, it's easy to discuss but not so easy to implement in a busy practice. So there are other people in the system who can be empowered to do these little things. So we've started a massive training program on wellness as well for the preventive care, because all these little things, they do it by themselves, and then it comes to the consultant. So whether it is anemia check, whether it's BP, whether it is blood glucose check, whether it's a BMI, the bone density, companies are willing to bring the machine and sit over there, so they will circle that. And then self-check of the breast, they teach the patients how to do it, and also do the cervical swab for the cancer screening. So it becomes a whole total comprehensive thing, and then they have to raise little points when they come to the consultant. So I think that the staff is super enthusiastic, and they can do a good job as facilitators for this entire process. And I think that will be a good model to follow if the wheel of wellness, what we are planning.
Absolutely. I agree with Dr. Hema. I agree 200% with Dr. Hema.
Yeah. So I think it has to be, we have to sensitize the next generation doctor towards personalized care plans, and to include patient in the personalized informed choice and cultural considerations.
I think, ma'am, as a part of training as well, just like we have postings in different departments, there should be a posting where there is an exchange between gynecology and psychiatry during the postgraduate training phase, so that we don't lose touch with each other's specialties and we know what red flags to look for.
I just want to add here that Indian Menopause Society is organizing these programs regularly, the Master to train the postgraduates, and there are modules which are conducted in the medical colleges. And also we have the CIMP exams, which are taken by the practicing doctors, and those doctors, they get trained and they pass the exam, and their names are also put on the website of Indian Menopause Society.
I agree.
They are the
I have no questions from the audience.
Traditional menopause practitioners they are.
Yeah. I have a question from the audience which I'm asking, which is the better route of estrogen administration in Indian scenario? Oral or vaginal? Because skin in Indian scenario doesn't work.
Dr. Manjula, oral has to be given. Where oral has to be given, oral has to be given. And where vaginal has to be given, it has to be given. Because for genitourinary problem, even if you give oral, you might need to supplement with vaginal.
Right.
And
next question.
When it comes to the for the MH for hot flashes and all, we have to give oral because the doses required are very high. And in our country, we do not have the high dose rings available, which again have to be inserted by a paramedical or somebody trained. And so they are not very popular, and they are not available in our country. So for that, we have no option except for the oral or sprays or gels.
Agree.
Manjula, I just to say that if they, I would look at the parameters also. Someone with a very high blood pressure or with high triglyceride levels or a active liver disease, probably a transdermal approach. Even someone with migraine, migraines are quite common. Migraine with aura.
With the heat.
And now transdermal routes are available. Transdermal patch, only
but the absorption and the stickiness.
Tell them about the 10 days, the 12 days of progesterone which they have to take, because it's a transdermal route.
No, the point with the transdermal in Indian scenario is about the heat and the sweat which we get.
No, the patches, you are absolutely right. The patches which are available, that they are sweaty, because of sweating not effective. But when we talk about gels and creams, they can be used easily in our country also.
Okay.
The only thing we have to tell them is, after applying that, don't go for a bath or a swim for 2 hours, and preferably don't rub on that. Once you finish the initial rubbing, just leave it alone. Don't apply any perfume on that particular side, something like that. Those, if you give them those instructions, it would work well. But the oral is quite popular. I would still say.
Running out of time.
Sorry.
I
Sorry.
just have 3 more questions to ask.
Yes.
What role do phytoestrogen supplements play? Do they play a role or no?
No.
No. Regarding the way of usage, is it sequential or continuous MHT? These are audience questions. Which one do you prefer? Is it continuous MHT or sequential, or do you take patient voice into consideration in those cases?
I think
Patient voice.
postmenopausal patients, yeah, patient wise, but even postmenopausal patients who don't have periods, they prefer the conti. The younger ones, early menopause, they don't mind having a period, but then eventually they want to move over to a phase where there are no periods. So you can do that switch over. But yes, patient's consideration is very important.
My next question was already answered by Dr. Uha. Can we use magnesium to improve pain and sleep in perimenopause? Yes, and the dose and the duration. Duration is something Uha can answer. It is 350 to 500 milligrams per day. Like
I
calcium,
think
do we have to continue using it?
I think duration depends on the patient's response. So it would be case to case basis. If the patient is improving, if the patient is also getting CBT simultaneously, then we might not have to depend on magnesium for too long, apart from for its other uses,
Yeah.
along with
So
calcium, but not for sleep.
the route preferred IV is IV oral or spray? I think oral, right?
Oral.
Yeah. And then how long to give tablet calcium? We continue almost lifelong because of the book. Anything else anybody has to do?
Calcium has to be taken always till you
Always.
are alive.
Next question, is it DEXA or BMD? But both are same. DEXA is nothing but bone mineral density. And last question, again, I think answered. So my last question, because our audience program is done, what are the barriers to implementing holistic care in menopause in your setting? What are the barriers?
I think I would consider awareness and the feasibility of implementation in variety of healthcare settings with different socio-cultural backgrounds is a huge barrier.
I think
I think
finding
this
a team, ma'am.
I
yeah,
would like to say here that we still need to bring in a lot of awareness, which is still
Awareness,
lacking
yeah.
in our country. And Dr. Hema is doing a great, great job by bringing this awareness. And that is what is the first need we have in our country, to bring in more and more awareness, so that not only the woman, her family, and the whole nation to come forward to help all these women of our country.
I think removing the fear of cancer, and that is again by increasing awareness. But the fear of cancer is very real. Every woman, for anything happens, oh, is it cancer? That's the first thing that they talk about. So that, and I would say even educating the family physicians and the gynecologists in general for because after the WHI people had stopped practicing HRT, and now there is a resurgence. There are newer studies. So I think education and creating awareness is very, very important.
You said very well, Dr. Suchitra. Now they are saying that you do not need to stop therapy if you have started therapy in time, and if it is giving benefit to the patient, you can give it even after 60. People are taking up to 70, 75 also, but you cannot start for the first time after 60. So, and it has to be, the risk benefit has to be measured.
So thank you all. I love my panelists. They answered very well. All the questions are answered. So I think menopause is need of the day. Personalized care is what we are looking at. And it's not an illness. It is transition. So no woman should go through it as unsupported. We need the help of psychiatrist and the dietitian and the physiotherapist. And it's a total coordinated thing. HRT is effective, but not for everyone. So we need to do size, and holistic approaches have growing evidence, and integrative care is to improve the compliance. Thank you. Thank you all. So anything else?
Dr. Manjula very well said. It is always a multidisciplinary approach. Whenever you treat any menopausal patient, you have to have a whole team of cardiologists, orthopedician, your psychiatrist, and everybody. So it has to be a multi-specialty approach.
May I just say something?
Yes, ma'am.
Since we've got about 2-3 minutes, the breast cancer survivors, they have a problem of, they've already gone through chemo, radio. They've got severe hot flushes, castration syndrome, particularly the younger women. So there's always a question, and I do get those kind of patients. Can we take some form, something to calm down the symptoms? Yeah, we always take help of someone like Uha that time. But I'd like to say here that if it's a triple negative breast cancer, today we're doing receptor studies for everybody. In those cases, we can give a short term chemo, HRT for a very, very short period of time. For the ones which are positive, of course, it's a problem giving even Tibolone, and those places where it's your alternative therapy which counts. But in someone who's having an absolutely bad state where they're also having meds, one of our physicians has said, please give them whatever makes them happy. So I just like to say that if somebody has patients like that, please refer them to a clinician who understands, instead of saying a blanket no to
Yeah, because
helping
I
them
think
to
the
lose
triple
weight.
negative stuff was mentioned by Chiara Benedicto
Chiara,
also.
yes.
It's also mentioned.
That extended
Yes,
investigations and applying our mind, and the helpline of those who have more expertise than us should always be very
Absolutely.
humbly sought for, I feel. Yeah.
Absolutely. So please allow me to leave. Thank you. Thank you all.
thank you,
Yeah.
Angela.
Thank you.
Thank you for conducting it so
Thank
well.
you so much. And one last time, we want to thank all the brilliant panelists who have
Yes.
honestly
They were
answered a
fantastic.
variety of questions that was posed by our esteemed moderator, Padma Shri Dr.
You're
Manjula Anagani, all the way from Hyderabad, and the makers of MGD3, Supracal 2000, Supracal ISO. I think it was music to their ears to see that there is a huge potential for the use of many of these across the lifespan, and also in the menopause, going right until menopausal age group. So the faculty for today, the team artists, humbly thanks them for being with us again and again and doing their best, because as we symbolically light the lamp every of the events, it is just to tell ourselves that the more the knowledge is disseminated, makes this world a better place. And each one of you contributing your valuable time, valuable expertise in trying to do as much and as many times as possible to the entire caregivers and care seekers, both teams put together. We thank on our own behalf, on behalf of Dr. Divakar, myself, Dr. Rita, Dr. Purni, team artist, who brings the Knowledge Cafe sessions time and again to see from confusions to clarity, even 1 or 2 points that you pick up from this entire webinar and change your practice. I think it makes a huge difference. Step by step, we move together, and Farmed has been kind enough to support these events ever so many times. And the Wheel of Wellness, which is going to be the in-house clinics with a great visibility, launched in small, medium-sized nursing homes very soon in Karnataka, but soon expanding to the entire country, to bring the sensitization of the fact that right across the age group in the wheel of her life, she needs to be prepared for the next part of her journey, the last lap being menopause. And we put our act together to do our best for the girls and women of this country every time, everywhere, and as much as we can, involving the synergy of all the experts like Suchitra Pandit, Anju Soni, Uha Susmita, and Chiara Benedicto, Manjula Anagani, who were on this show, many more to come. So we do hope the delegates who have joined us in large numbers have enjoyed this session. Thank you one last time. Namaskar.
And on behalf of all the panelists, Hema, we'd like to thank you for giving us this opportunity, you and your entire artist team. Thank you so much.
Thank you so much, ma'am.
For a
Thank you for
beautiful
having us here.
interactive session.
Thank you.
Thank
Thank you.
you.